Well, welcome everybody to episode 2 of Dry Eye Hive. And if you're comfortable, flip your camera on and we'll have some engaging conversation here. We're going to go ahead and get started. And there's a question in the chat and I'll just read it to everybody. It's what's the most frustrating business aspect of Dry Eye currently in your office? So obviously we're all here to help patients with their dry eye, but in order to do that, you have to produce income, which we don't really talk about in this profession. So if you just want to drop a line in the chat, what's your most frustrating thing? And then while we're doing that, we might as well introduce everybody. So maybe Dr. Beck and Dr. Fan, maybe you guys can give a shorter intro since we know you're from last week, and then we'll hop over to the Eyes on Shepherd crew here.
Dr. Fan, go right ahead.
I'm Peter Pham. I'm a practicing ophthalmologist out in Houston, Texas there. I'm also the founder of Zocular. I'm glad to be able to be here with everyone, and thank you for joining. And please turn on your camera so we can see if you get a chance.
Cool. My name is Dr. Ryan Beck. I am medical director for Dry Rescue. I practice down in South Florida 4 days a week and oversee a group of 8 different offices for primary optometry care. And again, just happy to be here. I'm not speaking on the Dry Rescue side tonight, just happy to help and listen in and chime in where, is appropriate. So more focusing on the aesthetics guys. And I'm excited to hear about from how things are going in their practice.
Awesome. So I'm Perry. I'm the moderator for tonight. My father is with me here, Dr. Brill. And I'm not an optometrist, but I worked in his practice, and I feel like I have a really good grasp on practice management side, operations, implementation, and marketing. And I'm mainly on the B2B side today. But I have brought some friends over here from Eyes on Shepherd in Toronto, I believe. And I think they run what is akin to my dad's practice, just super state of the art. I don't know how many lanes you have, 6 or 8 lanes. You always have been 5 years, 10 years ahead of the game. And that was really important to you. And with that being said, Dr. Salzberg, I'll let you introduce yourself first. And the crew here is kind of going to be our advisors tonight on how they do things. So.
Well, good evening. Thank you, Perry, for having us. Kerry Salzberg, we practice in central Toronto. I'm a second-generation optometrist. I practiced with my dad for about 25 years. So there's some similarities between the Brill son and father team and the Salzberg son and father team. We started with a very small practice 52 years ago. The room size probably about 300 square feet. And that included the waiting room, and we grew year after year. And this is our probably 4th iteration of our office. So we're now in 9,000 square feet. We have 8 lanes, 7 doctors, 40 staff. And what's nice about our practice is we've evolved to the point where every doctor has a niche. So Jordan does dry eye, Michelle does aesthetics. We have a myopia control scleral lens person. We have a VT doctor. So we try to refer to each other as opposed to referring out. So everybody has a niche, and we find that having a subspecialty within the practice really feeds the other areas. So we've been doing dry eye for probably, seriously, for about 10 years. We just never had the instrumentation up until about 5 years ago to really do it well. So, we fell prey to giving out drops 10, 15 years ago and getting people to take omega-3 fatty acids. And now we've evolved so much. And what's exciting about this industry, it seems like every 6 months to 12 months, there's a new device, new technology. And so we think the future is bright with dry eyes, but we also really love the work that we're doing with aesthetics. So I'll have some of my colleagues introduce themselves and we can talk more about that.
Cool.
Okay, well, I'm Jordan Friedman. I've been working with Kerry pretty much since I graduated in 2016 now. I did go to school with Dr. Beck over here. So if you push him enough, maybe he'll tell you some stories. Wait till you had a few more of those there, Ryan. Before you start too much. Yeah.
That'll be at the 10 o'clock hour. So you guys stay tuned.
Good. I initially had an interest in dry eyes in school. I went to Nova, and knowing that the big clinic in Toronto and on the ophthalmology side of things is the Bachner Eye Institute. And I heard that they had this new invention, this crazy device, LipiFlow, that would, pump your eyes out and essentially just rid yourself of all those, of all the debris in the eyelids. And I just thought that was fascinating. And since that point in time in my training, I've just been interested, in the field of dry eyes and all that it has to offer. Technologically, of course, too. It's been a crazy field, getting on the forefront of radio frequency with Carrie. It's really been an exciting journey. We've developed our own treatment shields to be used for these kinds of treatments that we've seen huge success with, and really developed a protocol paradigm around shield use in general, but iterations of these shields that make these things a lot more comfortable to patients. And now that we have aesthetics on the sides, I think it's a perfect marriage and a nice segue into Dr. Barron, Michelle Barron, who's been really spearheading that quite nicely.
Yeah,
Cool.
So thanks, Jordan and Carrie. So I'm Michelle Barron, and about a year ago, Carrie said to me, hey, what if we start to really take these devices that Jordan's been using for dry eye and utilize them for aesthetics? And I was a very tired mom of two trying to survive the pandemic. And so I selfishly said, absolutely. I would love to get my hands on these devices for aesthetic purposes and hit the ground running. And so aesthetics pretty much was, eye aesthetics was pretty much an idea about just over 14 months ago. And from there, we have, launched this whole other side of the practice. And, from a business point of view, and that's where Carrie's head is always spinning. We have the devices when they're not being used for dry eye, they're just sitting there. The patients always love to hear about the aesthetic component to these devices. Why not, continue further beyond the eyelids and the eye margins? And that's where we utilized it from a business point of view. From an optometrist point of view, and I can't speak for everyone, but especially as a female optometrist, more and more patients were coming to me with questions about Botox and questions about their lash extensions and questions about makeup for their sensitive eyes, and not having the answer for them at first bothered me. And that's really where my interest was even starting to brew prior to us, deciding to create the clinic. It was like, I need to know this information for my patients, because right now they're getting it from TikTok, and right now they're getting it from social media, and their eyes are a mess and they look disgusting. And people cannot close their eyes because they're being over Botox. And how can I help my patients make sure they have this safe space, that they're getting the right information, that they have the safe space for the aesthetic treatments they want to do, particularly those that would affect their eye. And so that's where, yes, there's that whole business aspect, which we're here for, but then there's also that providing a service to our patients where we brought in a nurse injector who's unbelievable, and, making sure she's, thinking of the eye and the ocular surface with every injection she does around the eye, that she is not over Botoxing them, that when she is doing filler, she is doing it in a safe way around the eye. So giving our patients who have been suffering from dry eye and need, a safe avenue, or just the average person, a safe place to do it. So it's been really fun. I love it. And happy to be here. So thanks, Perry.
Yeah, you're welcome. Thanks for being here. So as we get started, I just want everyone to know that this is interactive. So if you want to come on screen, you're more than welcome. If you want to unmute yourself at any time to ask questions, that's what we're here for. We're not here just to do a webinar presentation and sell you a product at the end, because we won't do that. So just unmute yourself if you want to ask a question, or you can put it in the chat and I'll announce it for you. Before we kind of hop right in, I just do want to show the Eyes on Shepherd website, because I think it is important to show kind of the quality of care that you provided and the experience we'll be talking about. So, here's maybe someone from Eyes on Shepherd could talk about how you designed this experience and why it was so important to the care or attracting the patients.
Yeah, so we wanted to, originally when we were going to build our new clinic, we were going to build it on site of our existing clinic. And logistically, it wasn't going to work out. So we ended up selling our practice. And it was the practice was basically 3 houses bridged together illegally because we were expanding so fast. And so we were just bursting at the seams. And I think one of the things that if anybody's going through the process of building out an office, if you want to build 4,000 square feet, make sure it's 6,000 square feet, because by the time you get in there, you're constantly going to wish that you had more space. So we leased this space of 9,000 square feet. We were going to sublease it. We decided to see what happens. And, frankly, we could probably use another 1,000 square feet. So because we built this during COVID, we have an expansive retail area, probably about 2,300 square feet of just retail. And we have these floating substations so that we can have, evenings, educational evenings. We can move the displays, we can shift things around. We have 7 lanes with a center hallway, so we can split the contact lens trials. So we spent about 8 years trying to figure out the best layout of an office. So we spent a lot of time and a lot of research doing this. And I think, what we have is, quite frankly, is a masterpiece in terms of design. And I say this without any ego, it's just that we put the work in. And I think that when it comes to dry eye and aesthetics and any practice building initiative, you got to put the work in. And I think a lot of people that are in the dry eye space, they suffer because they're not picking out the low-hanging fruit, or they're not marketing properly. So, doing that homework is certainly important for having a successful practice, but also having a successful niche practice like dry eye.
Cool. Awesome. Thanks for the description. I love the fact about adding more space. I know my dad knows all about that as well. You can never have enough. And you think it's going to turn into storage, and that 9th lane may be storage eventually.
Yeah.
Or it's storage at the beginning, but then you're like, okay, I'm going to get this crap out and actually make it something. So. Yeah,
100%. So we wanted to make sure that we had enough services to really, we have about 100,000 patient files right now. And again, we've been in business for 52 years. So, to make our service offerings grow and our revenue grow, we needed some of these niche services. And that's why we decided to go with aesthetics. And I think anybody that's going into aesthetics has to realize you don't turn on the switch and you have patients coming in. Patients kind of scratch their head and go, I understand about glasses, contact lenses, and maybe dry eye, but now you're doing Botox. And so you have to have a story that explains why we've kind of gone into this vertical. And I think it makes sense. We're in the market of beauty, whether it's fitting them with cool sunglasses or stylish glasses or contact lenses to get rid of their glasses. We are in the beauty space. And I think that there is definitely a natural evolution to going from dry eye to going into the aesthetic realm.
Hey, Carrie.
Yes.
Hi. I've got a question. Michelle was saying you hired an injector. So I've always wanted to do that, but in the United States, they would end up being an employee, and then I'd be responsible for that. And there's a gray area where if we are not licensed to do aesthetics or injections, you could probably hire somebody to do that who would have their own business, and they would be somebody that would be a vendor for you. How did you go about that? And tell us about how the laws are different in Canada versus the States, where we are tied often by our state boards as to what is legal or what is not, which also means, are we covered for our malpractice or not?
Right. So that was a question that we went through legal consultation and with our college. So the way we worked it is it's a separate entity. It's a separate corporation. And within that corporation, we have a different software management system, different billing software, and different liability insurance. So, even though it's housed under Eyes on Shepherd, we hire these people as a separate entity. And, I think we're on side with the college and with the, the provincial laws here. But it's a question that we get asked all the time in terms of how we do it. So it's a little bit of a headache separating the two businesses. But yeah, having that nurse injector is great, because what we found is that, Jordan will do RF treatment and get rid of the fine lines and wrinkles, the 11s and the crow's feet. And then they're going, well, I also have Botox, or I'm interested in fillers. So we have a nurse injector come in once a week to handle that, and we'll probably ramp up her production over the course of the next several months.
Great.
We also have a medical supervisor. So we also, from a legal point of view, as ODs, especially ODs in Canada, we actually can't inject at all. I think you guys are trained with that in the States. So we had to create a separate business with a medical supervisor. He's the one who's signing off. So it's actually his liability and his insurance that covers it. Then our nurse injector. In Ontario, for a nurse injector to do injections for every new consultation, she has to consult with him before she does the actual injection. So, and we pay, I think, per consult with him. And so that's how it works. So it's a separate business with him. And then we also have a medical esthetician that we hired. Again, everything being done through the aesthetics component. And she will do the full face. I know last week or 2 weeks ago when we were online, there was a lot of talk about, do we talk about the cosmetic benefit, how we can only treat the periorbital area? So Jordan will do the periorbital area for specifically dry eye. And then if someone wants the rest of their face done or any body part done, our esthetician through aesthetics will do full face RF or IPL. And we also have the Potenza Cynosure microneedling RF energy device.
I'll also do full face IPL anyways, because it is
For the protocol,
a dry
yeah.
eye protocol. So under just that alone, they're getting a photofacial along with a dry eye treatment.
How did you recruit an esthetician? Was it hard, or was it a natural fit when you went out to the market? Because I think when you say, hey, we're a bunch of optometrists, they're like, well, what are you doing this, you know?
Yeah, I mean, it was tough. And, you know, I think we've gone through some staff. We had a consulting group that we employed for the year to help us kind of build this project out. We have done things in the past where we just didn't have the business acumen to start up a VT practice. And we had a lot of missteps. So we wanted to make sure, because this is a new frontier for us too, we wanted to make sure that we had the right guidance. So this consulting group that we hired helped us find a medical director, nurse injector, and an esthetician. And I think we have a really tight group right now, but yes, a lot of bumps on the way.
When you say a
Do you get
consulting group,
pushback from, do you get any pushback from dermatology at all?
We haven't yet. We'll
No.
see. You know, I not yet. So much of dermatology here, though, to be honest, they're not even offering it to the same degree. You know, the Botox and the you know, that's what they do in their sort of spare time, and they do it fast.
Right.
You know, and there is, you know, there's so many medical spa clinics around, where to them probably just another one. And that's where you have to work to also build your niche. You're going into a very, at least here, and I'm sure like South Florida is probably even worse, like a very saturated area. And that's where you have to set yourself apart as, you know, and the angle we took with aesthetics is, you've trusted us with your eyes for 50 years. You know, let's continue that care when it comes to your cosmetics.
Yeah, you actually make a great point about South Florida, and maybe Dr. Ali can speak to this as well. There's basically a med spa on every corner. We actually built our clinic into what was previously a med spa. It was actually closed down about 1.5 years prior. We remodeled it and turned it into our dry eye rescue clinic. The one thing that differentiated us a little bit when we started doing full facial IPLs and IPLs in the periorbital area is that, and I'm not sure about the training in Canada compared to the States, but most estheticians and dermatologists were just saying, avoid the eyes, just get away from the eyes in general. Don't cause uveitis, don't go anywhere close to it whatsoever. And then now with the advent of using the laser graded cornea shields or V shields, or depending on how we like to do the procedures, we're able to get closer and treat those really sensitive areas to provide the dry eye relief. And that's kind of, you know, set us above and beyond to be able to do everything together.
when you're talking about the consulting group, is this group specific to that kind of medical spa market, or from another niche that we're unaware of?
Yeah, they know everything about aesthetics and skin creams, and they really helped us launch our different skin lines we were clueless. I mean, we were wet behind the ears. We had really no idea of how to do this properly. The fees associated with
Carrie trying all the different lotions was.
I've had some pretty significant peels in my 6 months of doing this. But yeah, I mean, I think
You
it's
look beautiful. So.
Thank you. Thanks, Harry. I think it's important to align yourselves with people that have gone through this, because the mistakes that you can make are costly in terms of the equipment that you bring on, the fees that you pay to your estheticians, the pricing of your packages. I mean, this was all new territory, and thank God we had this consulting group. And it was expensive. I think it's an investment. And was there a return on investment right now? Probably not, but I think it saved us hundreds of thousands of dollars had we just done it alone. So I'm glad that we have the foundation, and we're not quite there yet, but we see this as the future. And I think optometry will grab onto this, because there's definitely demand. And I have to tell you that a lot of my patients, I mean, most of my patients now that I ask, are getting filler and they're getting Botox, and some are coming with ptosis, some are coming with dry eye, and they may not be forthright in terms of telling me that they're having problems. But when asking, and this is the part of being curious, if you're curious with your patients, they'll tell you what's going on. And so it gives us the opportunity to either switch them over and give them an explanation of why they should be doing their aesthetics with our practice. And once patients are doing one service, they're looking at something else. I mean, we do full body treatments too. We have a lot of the radio frequency for fat under the arms and stomach. So, there's no end in sight. We're not doing hair removal right now, but we could see ourselves going in that direction. It's a slippery slope once you're committed. And I can attest, this is from my wife, she started doing a little bit of an injection here and there. Now she looks completely different.
That's funny.
I think they look for that service. At least for me, I agree with Michelle. Is it? Yeah, especially as a female optometrist. I know we're saturated for sure in South Florida, but it's because of that saturation they kind of come. I don't do a lot of the aesthetics, but I think I can venture into that realm soon. I do work in like a heavy cornea glaucoma disease practice. I work with MD, so I brought dry eye to them, but those patients are coming to me and be like, hey, you're a female eye doctor, you're treating the dry eye, what about here, what can I do for that? It's red here and it's red here. And they're coming to me because they're so saturated on the outside, they don't know where to turn. At least I'm a professional and they respect what I say, I guess,
Yeah. And I think if you open the stage for them to bring up their aesthetic concerns, they just start to spill the beans, and if you are, so most of you here probably have RF and IPL, maybe not all, but at least the ones with their cameras on up top, and everyone else is sitting and learning. But, if you have that RF, the next step for us was really bringing in that microneedling machine, and from an aesthetic point of view. So again, we cannot do it as an optometrist.
What is microneedling for us unaware?
So great question. Okay, so most of you probably know how RF works. RF is giving a really, really high heat that's basically creating a controlled injury to the skin from that high heat and causing it to create both collagen and elastin, and that's what gets rid of the fine lines and wrinkles and firms the skin and gives it a lift. Microneedling does the same thing, except it's an array of needles. It's about 21 needles that shoot into the skin quickly. And again, creating that controlled injury. So at a deeper dermal layer, so it goes down about 4 millimeters into your skin, you're causing it to have a controlled injury and stimulate collagen and elastin, but at a deeper level. RF does penetrate down, especially if you have monopolar, so it's driving it down, but the microneedling will go right down. And the Potenza, so the Cynosure device you have, is microneedling with radio frequency on the tips of the needles. So then you're getting that radio frequency going through as well. So you're getting a double whammy. And so this will just have a much more robust effect in how it can tighten the skin, contract the skin. And so we can even do, you know, like a minor blepharoplasty, like so it will lift eyelids. It will help with the lymphatic drainage around the eye. It will help with the texture and tone. So if you just give your patients the opportunity to talk about their aesthetic concerns, they come in like complaining about the puffiness below their eye, the dark circles around their eye, their drooping lids, the fine, like they'll just start to spill. So, so I absolutely, you know, agree with Felicia. I don't know if it's being female or if it's that we are now giving them a stage to talk about it. Maybe Carrie and Jordan will know more how much gets brought up to you now that they know we offer this. How much are they opening it up to you in your chairs?
So Michelle, Carrie, two questions. The first one is, did you do like a phase approach when you start the aesthetic, where you just brought in just the Botox and then you started then ramping up to the microneedling on through? I'm not sure you had the lasers in there as well for the surface ablation and all that as well, or did you just go all in and bought all the equipment for the aesthetics and then just offer the full gamut of options for the patients? And the second question is, of the options available for the aesthetic side, which one gives you the highest bang for the buck as far as the risk reward and the revenue potential profit?
Well, listen, when we started, we went with RF, and I always use dental analogies when I talk to patients about dry eyes, and I would liken the RF device as my toothbrush and my IPL as my dental floss. Because in Canada, we have all sorts of ethnicities, and whereas the RF is agnostic in terms of skin tones, IPL is not. We started with RF, but then we realized we had a lot of rosacea, we had a lot of demodex. There were conditions that we could treat, so we brought on our IPL. And then when we were introduced to the Potenza, it just made sense because we were heading in the direction of aesthetics. So in terms of dry eye, I think
Potenza is what, Carrie?
Is the microneedling
okay.
device. So I would say in terms of the dry eye, and I'll let Jordan speak to this, but I think the RF is our go-to device. But we bookend RF and then do a lot of IPL, and we package it out. So we were a little bit tentative. I mean, these devices are expensive. Right. And we didn't want to go all in. I'm the type of person that goes all in, but my CFO said, wait a second. But we've aligned ourselves with this company, and it's worked out great. But again, this is a slow ramp. We're wading in water right now. We haven't jumped into the pool fully. We don't have any surface lasers right now, ablative lasers, but again, that's something that we would consider. Jordan, you want to speak on the dry eye side?
Yeah, you know, so when we initially just started with more advanced dry eye therapy, first of all, the best tool, I think, if you're going to start, I mean, is a good footprint into it, is a myographer, because you really need to show your patients what you're doing. If they don't see it, they can't buy into it. And I know there's a lot of questions in the chat that are, how do I get the patients to convert? How do they see it differently than, you know, dry hands or chapped lips? And how do they get it to be an actual disease? But you got to show them, even an anterior segment camera, showing them their blepharitis and what you can do and how gross they are. I mean, you can be blunt, and, I don't like to use fear tactics, but it's just, this is you. This is what you look like. If you want to do something about it, I mean, you're here for a reason. You want my opinion, and here's what I can offer you. And so I found the RF was a really easy way to do that. You could do a really good job at expressing the glands, getting them feeling better, but you're also hiding those fine lines and wrinkles at the same time. Very, very safe. It's extremely difficult. You'd have to be trying really, really, really hard to hurt somebody and be totally negligent. So it is extremely safe to do. And they get the double benefit. So you're starting them on dry eyes and aesthetics. Even if your focus is totally on dry eye, they're getting the aesthetic benefit anyways. They're just going to see it. So it's very easy just to roll into it with RF, and then you can get a little bit more into things. Carrie, would you agree with
Yeah,
how we started there?
I think that when you, especially to a female person, when you say, you know, this is what we're using off label, but the on label use of this device is to treat fine lines and wrinkles and to tighten skin, then you see their eyes light up, and they've now justified it. You know, they're tapping into their emotional needs as opposed to the analytical needs of dry eye. Because, you know, I see from the comments, dry eye is hard to sell, especially if you're asymptomatic. And again, that's why we use dental analogies. When we first started talking about dry eye, I would liken it to gum recession. And dentists are fantastic marketers. They know how to sell. They know how to educate. And so when you're looking at gum recession, as a layperson, I'm like, I don't know, my gums are fine. And they stick that camera in, akin to a mybographer, and you can see the recession. All of a sudden, that you know, triggers a light that says, hey, I better do something. And what Jordan and I and Michelle try to do is say, look, we can only take this to a certain level. You know, you have X number of teeth, but you have 2 eyes, and we want to make sure that we maintain where you're at or even improve it. And we don't overpromise in terms of our treatment. We never say that you're going to feel 100% better.
No,
just as dentists,
that's key,
right?
You really have to
sure
set
clear
expectations.
Yeah,
absolutely. I found that to be crucial. You tell them exactly what's going to happen, and you walk them through it. And I found that the success rate with just the RF alone to be really, really strong. It's a great device to have. You know, you can get more into the nitty gritty of, you know, monopolar, bipolar, what have you, but I think it's really important to start at the basics and show them what issue that you're actually going to be helping them with. And it's nice that it makes them look prettier too.
I show everything. I think it's so imperative that you show everything. I I take out my cell phone, I take a picture, I show them, I look like, this is what it's supposed to look like. This is what yours looks like. And I think that's how I sell. I don't do sell most of my dry eye treatments, because I'm like, hey, this is what's going on. I didn't make this up. Like, here you go. I mean, it's how we get, I treat glaucoma a lot too. It's how I get the patients to be compliant with their drops. I'm like, here, look at your OCT, look at your visual field. This is what it's supposed to look like. I mean, you don't feel glaucoma. I mean, if you're having symptoms from glaucoma, it's really bad. So I kind of take that same approach because I'm doing both of these things daily.
I want to address Dr. Travis Lear's question, and he wants to know about preventing no showing of follow-up appointments, which, you know, can be costly chair time. And I'm assuming I know why they're not showing up. They don't feel the pain, or I guess you didn't build a case, and they're probably a terrible candidate for the follow-up, but you kind of forced them into it anyways. Any insight on that from the crew here?
I'm going to say, when are you asking them to follow up? Like, how long? What is that interval between your plan on seeing them next? I like to keep them on a short leash. For example, if I know that they need a radio frequency treatment and they may not be willing to jump right into it, and that's fine. A lot of people would prefer a stepwise approach, warm compress, maybe a drop at first. And if you ask them to come back in 3 months, they're gone. They're not going to come back. 3, 4, 5 weeks tops. Ask them to return on your treatment plan, a basic treatment plan. And then if it's not working, then you can discuss your other more advanced options further with them. But short leash is what really, I think, has been quite helpful in patient retention and those follow-ups.
I think that was actually. I'm sorry. Go ahead, Gary.
I was going to say that they need to know that they're going through a protocol, and and it starts with the first visit, depending on how many doctors they've seen. Often we're the 5th, 6th, 7th doctor they've seen, and then it's a little easier because now they've done some research. They're willing to drive 6 or 7 hours or longer, and now they've tried all the things. They've been to ophthalmology, where generally they do hot wash cloths and punctal plugs because there's billing codes, and maybe baby shampoo. So the 1980s treatment, because dry eye is kind of a pain in the rear for a cataract surgeon. They really just want to get to the surgery, and they may say, well, I started on Restasis a week ago, so I've dealt with the dry eye. So it really depends on what their goals are And I think during that dry eye workup, you have to have enough time with them so they develop trust, and they didn't know that this is a journey. It's not one treatment. And if somebody says, well, I just want one IPL treatment, I say, no, that really won't work. If they want to get started, and if right away with if they need LipiFlow, yes, we'll do the LipiFlow, of course, especially if we know that they've come from a long way. But what's interesting is how many young people that we have that are getting aesthetic treatments that we don't even know about. I mean, I have my staff in their 20s finally revealing they get Botox treatments, and we think, oh, that's just for older women, but it's not. It's for men and women, and a lot of times for younger people. So to get them on board, they have to get on board. If they're not on board, then nothing's going to happen. And a lot of times it's a matter of money. And so you can say, well, let's just start you on lid hygiene and nutritional support and maybe a steroid. And then, but if we start you on a steroid, we need to see you back in 3 weeks and they need to know why, because we're monitoring your eye pressure and your response to the treatment. If they don't buy into the treatment and they don't show up, then really there's not much else you can do. But a lot of times they'll wait, and later on they'll say, okay, now I am getting worse. And the glaucoma analogy is good because both conditions are chronic and progressive, and there's no pain or symptoms or awareness for a lot of people except the neuropathic pain people. So I think you have to get buy-in, and that's the best way.
All right, we're going to pivot a little here. We got some things happening in the chat. So Catherine Jew wants to know, how soon before dry eye versus aesthetic benefits are seen with RF? I think there's like 3 or 4 questions here, so we'll start with the first one.
Jordan, do you
sure.
want to answer the RF for dry, and then I'll just tag on with the aesthetic after that?
Sure. So benefits seen with RF, we'll do that there. Usually after the second treatment. Now, this will vary pretty wildly depending on what kind of RF unit that you have. Again, going back to the monopolar, bipolar, or multipolar functionalities of some of these devices, it depends on, are you expressing during, or are you bringing them back into a different room to express? So that kind of goes into, the protocol that you're doing plays a role into how soon benefits are also seen. I'm a firm believer in that you need to express while you're doing it. Strike while the iron's hot, otherwise you're almost cold expressing by the time you walk them back to the slit lamp room, and now you're at risk for causing like a back pressure and damaging the glands further, which is why I also don't express during IPL, but that's another discussion for another time perhaps. But after 2, I would say I use a monopolar device, so the heat is quite deep, it's quite potent and effective, and I'm able to reach a decently hot temperature quite quickly. So the simultaneous expression with a counterforce device like a shield can really squeeze out the glands nicely without hurting the patient's glands, without causing further damage. I spaced them 1 month apart, so by the second month, I expect to hear some positive results. But going back to setting the correct expectations, not every patient is going to respond the same. And they have to know that going in. Where in the disease stage are they? Do they have glands? Maybe they're just hanging on by threads. I'm not going to tell my patient who's just hanging in there that they're going to feel better. I'm going to tell them that I don't want them to get any worse or lose any of those glands that they have, because once they're all gone, we're in a whole different category. Now, someone who has a load of glands, they're quite a lot, and it's quite robust, and you see it on there, but when you go to diagnostically express, it's just not coming out. They're going to feel better maybe even after the first one, after simultaneous expression. I can certainly discuss more about my protocol. My protocol changes whether or not I add, for example, one of Peter's products into the line. I may do a Zest kit before I do a radio frequency, or bring them back for it at a different point in time. I may do it on the same day. I'll integrate IPL into these things, but strictly RF alone, I do monopolar 3 sessions spaced 1 month apart with counterforce shield and simultaneous expression. And then I do a 2-week follow-up to reassess everything. T-butt, a diagnostic expression to compare. I don't know if any of you are familiar with the NGE tool, but there is a whole grading scale with that I have used. I don't use that tool so much anymore. I've got a good feel with my thumb now, because again, you want these glands to express lightly on the force of a blink is how it should express. So you just want to gently press, and I'll compare that from day 0 to their follow-up after 3 sessions. And I usually always see an improvement in T-butt, gland expression, diagnostic expression. Sometimes you'll see regeneration from atrophy in my biography before and after pictures, which is always nice to see. But again, everybody's a little bit different. But short answer, after two treatments.
Okay. And Catherine or anybody who's asking questions, feel free to unmute yourself if you want to. I would recommend talking directly to Jordan or any of the experts here. Now is your time to get free consulting. After that, it's $500 an hour. So.
Answering the aesthetic question, Catherine. So right away, they'll see a benefit to the RF done pretty much anywhere, because it basically just causes a lot of swelling. And that looks almost like what we call, you can sort of pitch it a Cinderella glow. So there's very little downtime like IPL, which would have downtime. Aesthetically, RF, you walk away with a glow, your skin looks tight and taut and retracted, but that's actually more so inflammation and not the actual aesthetic benefit. It takes 3 to 6 months for new collagen to regrow. So anyone who walks away immediately after and they're like, oh my God, look at all my new collagen, which is pretty much what I did after the first time I had it. It's not, that's inflammation. So warn them from an aesthetic point of view, that's going to settle down after that inflammation dies down, but you're forever going to be creating more collagen. So 3 to 6 months is when that collagen is really in. From a cosmetic point of view, you're really looking, so Jordan does it for dry eye, 3 sessions, 1 month apart. That's really what you also want to do from a cosmetic point of view. 3 to 4 sessions, depending on how wrinkly they are, about 4 to 6 weeks apart. And again, they're going to even be seeing benefits, after that. And once you have the collagen, you have the collagen. It's just a matter of it then, fading away with collagen down the road. And you can, again, similar to that dental analogy, you need to refresh your skin, get in there, so you're going to have 3 to 4 sessions up front. And then, every year you can have a touch-up session for your skin if you just want to give it a boost, or every 6 months, give that skin a boost or a glow. And that's sort of your cosmetic advantage.
Cool. Quick question for you guys. I'm sorry, just in pertaining to the RF and the collagen as well. Are you guys ever combining treatments or like alternating? For example, you're doing these RF treatments 4 to 6 weeks apart, and then maybe in between 2 to 3 weeks in doing an IPL session and alternating for some cases. Does it provide any extra benefit if you do?
From a cosmetic point of view, absolutely. From a cosmetic point of view, really the more treatments you can layer on, the better. I know I'm sort of speaking for Jordan, but I know with his dry eye protocol, he absolutely layers those treatments, and he'll tell you how in a moment. But from a cosmetic point of view, they're doing different things. So if someone, wants a full package of beauty, you're looking at, building collagen and elastin at a deeper dermal layer between either RF or that microneedling RF. And then if you want to even out skin tone, have better cell turnover, make smaller pore size, and clear up skin, then and just like you're clearing up rosacea, and that telangiectasia from rosacea, I think IPL affects browns and reds. So you're going to be hitting all the browns and reds in your skin. So getting rid of freckles and sunspots and, the dilated vessels around the nose, everything that you think when you think of rosacea patient. So they're doing 2 different things. So absolutely. We have our medical esthetician do basically like a skin consultation. What are your goals? What do you want to get out of this? These are the treatments we offer. And then you can absolutely layer on packages. You can do RF and IPL 2 weeks apart. So you could often do, RF 2 weeks later, do IPL and stagger them that way. Our medical esthetician also does chemical peels. So you could even, again, if you want that better cell turnover for the skin and just that glow, layer on an energy device and a chemical peel every 2 weeks. So absolutely, like, let them get multiple treatments. Go right ahead.
We had a question from Maria Zamora here. I'm going to announce it here. Are you including aesthetics treatment along with dry eye treatments without charging extra? For example, doing RF with the shields on eyelids with expression and also doing periorbital area without the shields for the same price?
I'll go for that one. The way we've been doing it so far, and it's just part of my protocol where I do the periorbital area. I want to acclimate the patient to the heat that I'm using before it touches their eyelid. The eyelid is very sensitive. We are using heat, and that heat is spread over a 10 millimeter space that you're gliding over a slightly larger surface area that's quite thin, 1 to 3 millimeters of thickness, depending on person's age, race, etc. So I found, and I've tried both ways. I've tried starting on the eyelids first and forgetting the periorbital area. And I can tell you, sure, you'll get to temperature, but patient comfort is definitely something that goes with that. So I found by going around the periorbital area first, they get the benefit of the aesthetics, but they're acclimated to the temperatures that you're using, because the heat will radiate. It's pretty close to the eyelids. So instead of starting cold on the eyelid and trying to get that up to temperature, we're starting at about 36-ish degrees, 37, depending on how much water they drank beforehand. And then so I'm only really trying to get up another 2, 3, 4 degrees, and then we're in a nice treatment zone.
Okay. Dr. Beck, I want you to hit this. We discussed it a little last week. It's from Maria again. Do you recommend to offer treatment plans with different tiers of treatment at the dry eye evaluation, or just go for the full highest tier treatment plan, which is usually the most expensive? I'll summarize the next portion. So she says, it's great when they buy it, but when they consult their financial team, aka their spouse or their piggy bank, they lose the patient. So what is your process for getting a conversion to getting people to follow a protocol?
Oh, sure. I appreciate that. So essentially, what we started with was the rule of threes. A lot of people like to have things broken down into, 3 different options or 3 different things to be presented with, like a good, better, best type of scenario. So based on the patients that come in, we have a mild, moderate, and severe kind of level of packaging to be able to go with mild, moderate, and severe level of diagnoses that come through. The mild will start out with essentially the things that you can get with over the counter, the nutraceutical supplements, the drops, lid wipes, lid cleansers, things along those lines, doctor directed at home care, essentially. And then increasing more to add in some of the doctor directed in-office treatments or pharmaceuticals with the moderate package, and then up to the severe package as well. And showing that there were differences in the levels of treatment that we were doing to correlate with the severity of their disease, especially with the imaging that you guys had mentioned before, was really, really key. The mybography scale that we use, we're actually using the Oculus Keratograph 5M, has been really powerful. They have their GenVis scale that shows the normal, mild, moderate, and severe of the degeneration of the meibomian glands. And when you can show 70-80% dropout that has already occurred, and say, look, we need to hit this with IPL, LLLT, plus we need to clean off those lids with a Zest kit, and maybe get an expression going with LipiFlow afterwards, just to be able to throw the kitchen sink at it and get as much function as possible. They're like, wow, yeah, I'm already at the severe state. We have to go. We have to do this, because otherwise I don't want to be so dry that I can't even see afterwards and turn into a Stephen Johnson syndrome patient for some reason. So that was more of the recommendations. Go for some initial packaging, and then as you get really comfortable with these packaging, starting to edit it based on your experience with the patient. You could have somebody who's in between and say, look, I'm going to get you started with the mild package, but I want to add in this one extra treatment from the moderate side to be able to bridge in between that level. And then the more patients you see, the more comfortable you get with it.
Okay, cool. I think that's very helpful. Dr. Pham, I want to pivot to you for the aesthetic side as well. And I know with the Zocular product, I mean, you take people with acne, I believe, and have improvements without, investing in RF. What do you have for recommendations for some aesthetic improvement without, major investment, so we can do it, tomorrow rather than have to wait till we're really ready and take that financial plunge?
That's a really good question there. So a lot of it, a lot of aesthetic doesn't have to necessarily have to do with wrinkle, as you said there. A lot of it is just blemishes that are in the skin. And dry eye is probably one of the biggest blemish, quite frankly, because they can't see and everything looks bad in their eye there. And so, but this is why just having a bare minimum treatment for dry eye is so important. And as you mentioned there, we also have some products that also work on acne and also on wrinkles. We do have another product for the wrinkle side that is more that works on the inflammatory issue related to wrinkle, as Michelle had alluded to there. The microneedling induces that low-grade trauma to the skin to then generate that healing response there. And that's how most plastic surgery works, right? Is that we're trying to always induce a traumatic injury to the tissue in order to get the secondary inflammatory response that brings in the necessary healing response to do the elastin, collagen, et cetera there. But, our skin is and most tissue in our body is a dynamic process where there is both an anabolic regenerative process and a catabolic inflammatory process that kind of degrades tissue as new tissue is being regenerated. And as we get older, that kind of anabolic and catabolic process no longer balances, right? And so you end up with basically a difference between these two processes, where the catabolic process is at a higher rate than the anabolic process, right? And then that leads to that loss of tissue architecture and loss of collagen and elastin that leads to the fine lines and wrinkles. And so our thought was to, well, if you can now lower that baseline inflammatory process, you can almost allow even at a lower state of the catabolic process going on, you can lower that. And so the anabolic process, which is also decreased with aging, can now match the two. And that's how you can kind of resynchronize the two cycles, the kind of yin yang of tissue regeneration.
Quick question about the microneedling process, because it's something that we don't have in the clinic yet, but it's something we're starting to explore. And for people who are not as familiar with it, is this microneedling actually puncturing the skin to be able to actually go through? Okay.
Yeah.
Yeah.
Yeah. All right.
Which
so I understand that that's the scope can be an issue too.
Yeah, Carrie, from the legal aspect, because you did all the legal work, we had to have the medical director for the microneedling, correct?
Not for the microneedling, just the injectables.
Just injectables.
Yeah.
Okay, so the esthetician, because they get licensed, not licensed, but accredited by the company, by Cynosure or whoever, and then they can do it. But we as optometrists, under our optometrist hat, cannot be doing it. So that's why we have the medical esthetician do it.
And when you're doing the Botox, are you charging by unit or are you charging by the procedure type?
By unit.
By unit.
By unit.
Yeah.
But our approach is less is more. I mean, we see some people that are just over Botoxed and
yes.
Right.
Yeah. Exactly. And which Botox do you like to use? It the Xeomin or the Botox, or?
We use the Dysport.
Dysport, okay.
Yeah, we use Dysport right now. Our nurse injector, it was her favorite. Just in how quickly it acts and how long it lasts. Post-procedure headaches were minimal. I believe because people know the Botox brand so much, we are setting up an account with Allergan to bring actual Botox in. But if we had it up to us, we would just continue forward with Dysport. It's really more that brand recognition that gets Botox.
And from a more granular level, mechanistically, are they putting some sort of topical anesthetic prior to that Botox, or are they just going straight in with
Not-
a 31, 32 gauge needle?
No, not the Botox. She just goes in. She's really gentle. It really doesn't hurt. Microneedling, we do numb with an anesthetic beforehand with like a benzocaine numbing cream about 45 minutes to an hour before we do the microneedling.
Are you actually doing microneedling on the lids?
You can get, as long as you can do it onto the orbital bone. So you can pull, you know, so sorry, I mean, you're eye doctors, you're used to seeing it live, but you can pull down and basically hit right across the bone. You can pull up again and hit right along the bone. And so you'll see, you know, a lid retraction. So for myself, 24 hours, not even 24 hours after, my lids were like right off my lashes. So, so that was a really, you know, big, no pun intended, eye opener, that was just how well it lifts the lid. And so any patient now who comes in complaining to me about sagging eyelids, I basically run through 4 options for them. I can send them to a surgeon to have a blepharoplasty, and they all go, oh, I don't want surgery. And it's like, okay, great. Because then I have 3 other options. One is the microneedling, because that will get your lids to lift, you know, a few millimeters. One is Botox, because if you do a few units of Botox, it will lift that brow, but that's going to wear off every 3 to 4 months. You'll have to keep redoing that. And then one is radio frequency, which is, you know, really your safest, the least invasive, and you will get a few millimeters retraction, but not as much as the microneedling. The microneedling will give you a more robust effect. If anyone wants to see some before or afters, feel free to reach out. I'll put my my contacts in the message for Perry, and we can send you some before and afters. And I can also give you my Instagram handle, and you can DM me, and I can just send you my own photos or whatever if you have more aesthetic related questions.
I mean, if we could pull up your Instagram now if you want. Just
Yeah.
And
So go ahead. Yeah, Dr. Pham.
Are you doing a plasma pen as well? That's another
No,
kind
we're
of
not.
cheaper version.
It's a cheaper version. We spoke to I'm just also going to move because my computer is going to die in like 2 seconds. Everyone's going to see my messy bedroom. We
Casual. That's why I'm in a t-shirt. That's why I'm here. So.
Right. I have 2 little kids, guys. We spoke to our consulting team about the plasma pen, and the results, he didn't love it. He said, you know, the results really aren't so great. We get a much more robust effect with the microneedling. So we were already bringing in the device, so we just stuck with that. But yeah, no, I've been really, really happy with the results. Even, you know, the puffiness under the eye, other than doing a lower blepharoplasty, really hard to eliminate that under eye puffiness. And, you know, you will get, same with RF also, and Jordan, you probably see this all the time on your patients, that better, like improved lymphatic drainage from underneath. It won't go away. You know, so again, setting expectations. If they want it to go away, they need surgery. But if they want to at least improve it, it will help. So yeah, so I'll put in my message. But so my Instagram is at @EyeCareMom, EYE Care Mom. You can also follow on Instagram our actual clinic if you want, at Aesthetics. What are we at? Aesthetics Toronto. I should know this. I can write the page. And I'll put my email also. If you have aesthetic related questions, you can absolutely reach out. Just going back, you know, we're preaching a lot about aesthetics, and you guys are all here for dry eye, but just another really easy way to get into the market, and even to start to bring up the questions with your patients when you're dry eye doctors, is bring in cosmetics that are good for the eyes. We're really blessed. All these really great cosmetic eye lines just came out for patients. There's 2020, which is by Dr. Hillel Campo out of New Jersey. She's unbelievable. She is so stringent about what goes into her product. Her products are really good quality. There's We Love Eyes out of California. That one's really well known. There is Eyes Are the Story, another great line. There's a few more coming out. There's some skincare lines coming. You guys in the States have from an ophthalmologist in New York, Daily Rescue. I have no financial investment in any of these brands whatsoever. I just really like the product, and I really like being able to offer my patients these products who have sensitive eyes and who have irritated eyes and they're complaining. And it's like, you know what? I have the best product. And then when they see that it works and they trust you for that, you know, you've gained some trust. And then you can show them, okay, now we have these procedures that can also help with your dry eye, or, you know, you're going to get them to invest in all of these expensive procedures to help treat their dry eye, but then they're going to put on their like loads of makeup full of carbon black and preservatives. And, you know, there goes all that treatment. So again, if you're interested in the aesthetic world, but want to take baby steps, just bring in a few and stay within your scope of optometry, bring in a few, cosmetic eye lines. They're great quality these days.
And I want to talk about the product side. And Dad, you always did a great job at this of selling products. And I think as optometrists, we think, oh my God, we can't sell the product. They just want to go to CVS anyways and buy their 10-gallon bottle of BioTrue, right? So you have to actually display the products. And then in our practice, you come to the front desk. We had a nice bookshelf display. Everything was front facing. My family comes from a line of grocery store operators, so we know how to face products. And it has to be fully stocked. You can't just have one bottle there because it looks like it's that dusty bottle that no one wants off the bottom shelf. And Dr. Beck, I know you are very big into merchandising, and so like after a treatment, you have to be like, hey, here's your products that you're going to buy. Here's why you need them, and here's how to use them.
Yeah, Ray, I'll let you speak first. Go for it.
Yeah, I was going to say that we prescribe them in a room. You know, we discuss this in the room, and then it's just a matter of picking it up at the front desk. So we look at it as part of the treatment modality, and it's part of their instructions. So I did have a question for Michelle. What do you do for nocturnal lagophthalmos or just a poor eyelid seal? I mean, that's something optometrists miss quite often. You know, they miss Demodex because they don't have them look down, and they miss a bad eyelid seal. Do any of the treatments actually make it worse, or what do you have to make it better? Because that's a big problem, exposure at night for a lot of patients.
Yeah. So, I mean, I think a big part of the eyelid seal is too much Botox. I think sometimes they need to take a Botox break and just see what returns. You know, and I know that once that really great blink is sort of gone, you sometimes lose it forever. They'll never get that full blink back. I don't have research behind if the microneedling is going to cause too much of a seal, but again, you're not lifting the actual lid itself, you're lifting the brow. So
Okay.
You're lifting that excess skin, you're retracting that. So other than the Botox, I'm really not that worried about lifting the seal. And if anything, I actually would be interested if someone wants to do a study on perhaps the RF and maybe the microneedling RF, but again, you're not getting as close to the eye as you are with just RF because you're not going over the lid itself, but might actually help if you really have loose lids and you're not getting a good tight squeeze that will pump out the meibum because your glands are so loose. If rebuilding that collagen to actually make a bit of a tighter lid is actually going to help be a better pump. I don't know. I'm just thinking, could this be a possibility that there's actually a benefit to rebuilding the collagen and strengthening that lid, you know, from that. The only one I'm worried about is Botox. You just don't really want to over Botox because that's where you'll really, you know, they're going right into the orbicularis muscle. You're weakening the orbicularis muscle and you're decreasing that ability to even have a blink.
Well, let's say at night, let's say during your workup, you notice they have inferior staining and they're more symptomatic in the morning. Other than like an eye seals 4.0 or an ointment, what is your treatment for exposure? Since that's a large problem, And there's, of course, exacerbated if they have sleep apnea or wear CPAP.
Right.
How do you address that? Because that seems to be some pushback on wearing a mask at night or even using an ointment. So how do you address that practice-wise?
No different than you. I send them to Jordan. And say I just do the aesthetics. But no different than what you're doing, I would ask them, if you're not already, do you do Botox? Men and women, don't. So, because again, that could be a reason that's just going unknown. And then, from an aesthetic point of view, there's really nothing to do, making them more aware, more mindful of it. Again, I don't have research behind RF actually helping to improve it. But out of all those options, and also pivoting it, if someone is getting it because of their Botox, like if they're getting like ophthalmos because of their Botox, you now have another option. Say, you know what? Botox is making this worse. We have to take a Botox break, at least from around your eye. But at least instead we can do radio frequency, something that will help your dry eye, but also at least give you some cosmetic effect and help with reduce your fine lines and wrinkles in the meantime while you can't get it. So I had through Instagram a patient reach out to me who basically attributes her really bad MGD and dry eye from Botox, but she also says she's so upset that she can't do it anymore. And so when I told her about RF and that there's at least an option and this can also help to treat dry eye, she was so excited about it. And I said, great, come to our clinic. And she lives in the Dominican Republic. So if there's anyone, so the power of social media, if there's anyone in Dominican on here, let me know. I have a great patient for you.
So are they doing the nasal and lateral lid injection for Botox just for wrinkles, or are they doing it for blood flow spasm?
Both. They
For
can
both,
do it for
okay.
wrinkles. Yeah. Oh, absolutely.
Okay.
They'll do 3 units here. They'll do for blepharoplasty 2 units.
But not on the
here.
upper lid though, right? Not on the upper lid, on the nasal.
Not on the lid
Okay.
itself.
Yeah,
No. You're raising again from the
Right.
brow.
Got it.
Yeah.
Harry, I'm going to, if you put me on my phone, I'm going to sign in because I have to pick up my my daughter from dance, but I'll show you how we merchandise our cosmetics, and I'll also go into the aesthetics room and just show you how we've outlined that, and then I'll be on in the car.
Cool. You're going to give us a little quick tour?
I'm going to do that now. Yes.
Okay. All right. We'll see you on mobile. So.
Sure. And in the meantime, I can also see if I have any pictures of the dry rescue clinic that we just put together, ours as well. And then actually kind of circling back a little bit as far as that lid closure discussion, this is actually one of the reasons why we've been looking into the plasma pen, just because doing a non-surgical blepharoplasty to be able to help kind of adhere a little bit better and get some better closure for those MGs for better expression is something that was interesting. One thing that was actually brought up at Dry Eye University in Jacksonville just this past week or two ago was one of the plasma pen companies, Nuvisa. They had actually developed a new tip to use the plasma pen for CCH treatment, which I thought was super interesting, and especially in causes with lag ophthalmos and improper blinks and things. There's not a lot that we have for CCH in general, and I think it's one of those underlying causes that we know can be benign, but also can be problematic as far as ocular surface is concerned. And if you can kind of get some multiple modalities out of treatments for the for one device, then it makes sense. Kind of like you guys are doing with RF, right? You're using it both for the aesthetic side and the dry eye side, but if we can do that for a couple different devices, then you really have some flexibility about how to be able to design your treatment plan. And it looks like we're getting a really good view of the Eyes on Shepherd right now. That looks phenomenal.
Yeah, Carrie, we'll let you give the tour. I'm wondering who takes care of all the plants first.
They're all
They're
fake.
fake.
They're fake.
Okay.
Don't spoil the secret. So this is our front entrance, and we're going to establish another desk here, but our products are over here. We carry 2 or 3 lines. We're actually going to do chemical peels. We're going to have a cross promotion. When you buy glasses, or if you're a VIP patient, you'll be able to do a complimentary chemical peel here. This is our clinic. And I'll just take you. So we also we repurpose the refrigerator, and we sell
Nice.
our products here. We actually have our own line of beer.
Love that.
What's
Are you
the?
guys hiring? Are you hiring?
So in the back here is our treatment room. So we have a consultation room in here. So it's nice and private.
Feels like kind of when I got orthodontia, you know, they bring you into that consultation room.
And here's our aesthetics room. So all our machines, this is the temperature device. We have the Potenza and the IPL, our treatment chair or sink, and all the ancillary products here. So it's nice and quiet. And yeah, I mean, I would say that if you're building out a room, this is probably double the size. This is probably about 13 by 17 feet. And it's just enough space to have the esthetician and the patient and any other technical staff be in the room without it feeling a little bit too crowded.
So you treat from behind the patient for a lot of these?
Yeah, or on the side. I mean, Jordan will, yeah, typically almost like a dentist treats. I'll just show you.
I treat from behind for the RF, but on the IPL, it's whatever's more comfortable for you. The patients are usually more in an upright posture, and I can just bounce around from side to side pretty easily with the IPL.
That marble floor?
It's an epoxy, looks marble.
Wow, beautiful.
That's great.
And then this is our pre-test area here. So we have, sorry if you're getting dizzy. And then we have a center hallway. So all our contact lenses are here. And then we have 4 exam rooms on one side, 4 exams on the other.
Are you doing specialty contacts too, Carrie?
Yes, yeah, scleral lenses, myopia control, ortho K, and then this is our administrative area, and we actually have a dedicated phone area. So that way you don't hear the phones ringing in the front.
Now, do you enter from the back of the room and the patients enter from the front of the exam rooms? You have
Yeah, I mean, we do it
doors?
both ways. We like to, you know, sometimes the patient will be brought in by a technician, but this allows us to go from room to room if we have a question or if we want to grab product. And it's, you know, everything's kind of hidden in the back. So there's a door here that we can shut just for privacy, and it has a certain film on it. So that's the office.
Almost
It's a
looks like
gallery.
it should be in a mall.
And with that, I will leave you and join you in the car.
Sounds good. Appreciate it.
All right.
We'll take you off the spot. You're on spotlight. You can't see it, but we got a nice clear view here. So
Beautiful.
I'm gonna take.
Do all the doctors have their own little offices?
Just Arlene.
Just one. Okay.
Sure.
Yeah, just
we
Arlene.
have our own lanes, but not like a
Mhm.
dedicated office room of our own. So we each have our own examining lane.
Cool. We're probably going to go for another 15 minutes and then wrap up. So any final questions from anybody that's burning, dying? You can ask it via audio or chat or any other topics you want to discuss.
So Michelle, Jordan, are most of the aesthetic patients coming directly from the dry eye clinic, or are you having a dedicated portion of them coming directly to you just because they want the aesthetic side and there's not even any dry eye treatment associated with it?
I think, well, Jordan has had, like, before we even started aesthetics, I think, I'm speaking for you, Jordan, but a lot of patients who, you know, once they were getting the RF and were so happy with it, again, he's doing a full face IPL for those who could get it, but then a bunch of them did opt for, oh, can you finish off my full face? And then, you know, our staff member esthetician would take care of the rest of the face because they just saw that aesthetic benefit. Since launching aesthetics and branding that itself, and I don't know if you saw in Carrie's tour also, there were those screens, that was me talking on a screen. People are seeing us advertise it to them while they sit in our wait room and watch about it. We have a number of patients through all the doctors that now are like, oh, you do this, you know, and so we're getting that flow where they bring it up with myself or one of the doctors in our own lane, and then we make that referral to the esthetician, and the esthetician closes the deal. And then we're also getting word of mouth now, and that's where I think we're really going to start to see it grow, is once, you know, that person has it and was so happy with their treatment, that's how you really grow within this field, because again, it's so saturated, they want to go to someone they know. So it's, I'd say, you know, half and half from the dry eye patients themselves, and then the patients that are just having aesthetic concerns that we're converting from our lane, and then a small percentage now coming in from word of mouth, and we're looking on building that. You know, we're trying to build a robust social media presence. We have gone and networked with a number of mummy groups, which is really my demographic. So getting our name out to, you know, tired moms who are sort of broke also. So I don't know if that's such a good avenue, but you know, we're definitely going out there, and there is a lot of marketing ideas that we have, and I can share with you. It's a matter of getting to them, but it's a whole different business side. It really is, because of the market saturation, because what we're offering. And I think, I mean, as an ophthalmologist, it might be different for yourself, but as optometrists, I think we feel so tied by our college and by our you know, our rules, and we shouldn't be advertising or whatever, but the aesthetics is different. You will have to sort of do that if you really want to penetrate the market.
Michelle, how do you deal with collaborative eye care? I've been trying to crack that nut for a long time, because it's very difficult to have colleagues / competitors, both ophthalmology and optometry, refer to you. I mean, you have a beautiful office. And not everybody has that beautiful office. And I know we have a really nice office. So people, ophthalmologists would ask, well, tell me, do you do your dry eye spot inside your office, or is it another suite in your building? Which is a real, you know, interesting question from a large ophthalmology group. Or optometrists just still, no matter what, they think you're going to steal their patient. And we tell them, you can shear the sheet many times, but you can only skin it once. We obviously want referrals. We would not do anything. Even if a patient says, I never want to go back to that other doctor, we say, we cannot see you for any of your routine care that you would get. So how have you addressed collaborative eye care and referrals?
So to be honest with the aesthetics, we haven't really gotten outside referrals to us yet. Again, we're about a year old. And like Carrie said, we're blessed with the fact that we do have 100,000 patients. So we have a high volume of patients coming in. But I know Jordan probably gets that more from a dry eye point of view, because he does get outside referrals from ODs to his dry eye clinic.
Yes, so I do have I have a local oculoplastic surgeon who's literally right across the street from us, Michelle, Dr. Gill, who actually does have a dermatologist there too. So he's in an aesthetic industry. He's in with dermatological treatments, and he will still refer to me to do the IPL around the eyes. He doesn't want to do it. He'll have patients that'll be symptomatic after they have their eyelid surgeries, or want to clear up any dry eyes before they have their eyelid surgeries. So from the ophthalmology perspective, I even have support of a few of the local OMDs, which has been really, really great. Other clinicians, other ODs around that don't have access to the technology will refer. We have a presence on a few different dry eye platforms that you can search locally. You can type in, you know, your address, and then clinics pop up, and it'll show your practice as being close to them, and that's a new patient, not necessarily a referral, but that's how a new patient might find their way to our office and into my chair. Yeah, there's loads of different avenues too. Michelle's been doing a great job with Instagram, getting a ton more followers. That's where we're all looking these days, is on social media. So by having a presence, I think that's going to just be another brand new avenue where you're going to get
I know
base.
I know, Dad, you know, you had the concept of, look, if you have a bunch of optometrists in the area who are not doing dry eye, invite them over to your office and show them, hey, here's how I do a workup, and you can do it too. And that way you're kind of building this collegiality. I don't think we ever executed it as well as we should have, but
Well, we did, but we got 6 ophthalmology practices to buy LipiFlow after I did that. So I was an unpaid salesman for 6 ophthalmology offices, and I'm sure that their LipiFlow is just sitting in a corner somewhere because they kept lowering the price down to even $400. I mean, which I don't know how they made any money on that, because that's when we started back in 2014 with LipiFlow. I mean, it was $800 for 2 activators, and then they taxed us on it. So, but I think when you get down to the lowest price, people were finally saying, I called them and their price was so low, I thought something was suspicious. So often, just like the highest priced LASIK clinics often are the busiest. So we maintained our pricing because of the value proposition. But so it's nice to know that our optometry's dirty little secret is that we don't refer to each other by and large.
Yeah. And I mean, I think that's the problem with any specialty clinic. When I started optometry, I started in vision therapy, and it was the same. How do you get other clinics to flag these children who needed the help and refer to the vision therapy clinic? And I think it really is trying just to really build good collegiality with your with the clinics around you, and show them that you're not taking them, and they should be doing right by their patient. If they're not willing to go ahead and treat it, and there's an option out there that can make this patient better, they're doing their patient a disservice. And for what if they have that confidence that you will send back? So again, you could invite people back over to see it, and maybe don't actually teach them what you do, but just show them or show them how you make the arrangement. Reassure them that you're strictly doing this. They are flagged as your patient. You are going to get all the reads, all the glasses, that you're not doing anything more. And then I guess you just building trust. I mean, that's what we had to do with the BV kids also. And some will refer and they're doing right by their patient. And I think others will never, because they're insecure.
Yeah, but we actually,
the flip side of that is if they don't refer, then they will lose their patient. So a lot of times, if we just had the concept, just do what's right for your patient. If you just do what's right for your patient, you will retain that patient. Nobody thinks of a dentist, since you're using a dental model, a general dentist that refers for endodontics as that general dentist is stupid or impaired. But in the States, optometrists take a couple of classes: 1, the vow of poverty, and 2, the inferiority complex, as far as other optometrists and ophthalmologists. So I must have missed those classes, because I felt as an American and a capitalist that our job is to stay in business so you could provide care, buy more technology, employ more people, help more people. But optometrists are still, I think, in the States, by and large, and there's different cities that are different, but they are siloed and really are afraid to show their office to a lot of other people. And when you have somebody that has a stellar clinic like yours, I mean, it's almost embarrassing for them to refer.
Yeah, Dr. Beck, why don't you hit that, and then I have a few concluding thoughts. So
sure, actually, so you guys have actually hit on something that we really just instituted, an aggressive program to be able to combat recently. So we started out most of my dry eye services in a comprehensive clinic, just like Eyes on Shepherd, but we actually grew too big to be able to also do comp exams at the same time. It was actually infringing upon our comp exam appointments. So we moved it out to a separate med spa facility, just as a dry eye standalone clinic in that regard. And to be able to get more well-known, we actually went aggressive, just like some of the ophthalmologists in the area, and started doing co-management for non-cover services. We actually just said, look, you're sending over to an institute that's down the road. You're getting $100 for a LipiFlow referral. We're going to do $150. If you are going to be sending over and the patient does a $1,200 IPL pack for 4 sessions, then we'll do $150 for that. And then on top of it too, in addition, just because we're associated with Dry Rescue and we do the wholesale ordering side of things, we also didn't want people to feel like they were going to be losing product sales from their offices to our offices. So we're also giving co-management on the product side for people who send out to our clinics as well. And because of all that, not only do they not feel like they're losing their patient to somebody who is just doing, high level ocular surface care, but we're making it worth their while. To be able to actually co-manage with us. We set up a referral form to be able to say, look, are you sending over just for treatment, evaluation, and treatment? Do you want to do true co-management with us? Are you just sending us your patient to get rid of? How do you want to make this work? And then from there, we've actually, had our CFO and financial department create this whole kind of software system, this whole tracking system based in our EMRs to say, all right, this is the associated referring doctor. This is how much was spent on non-covered procedures and products from that patient. Cut them a check for this every month. And then it's continuous. It's not just for the one procedure. So if every month where that person is spending more and more, it just builds and builds and builds. And it's another revenue stream for these local doctors who are afraid of losing the patient anyway. And then they're coming back because we're not prescribing glasses or contact lenses at our clinic, to that location too. So it's a win-win for everybody in general. Yeah, we take a hit.
Is that legal to do? Is that actually legal to do? Because if it sounds like it's a kickback versus a co-management. I'm just asking the question. Sure. And how you get around that, because somebody might say, wait a second, you're paying them to do nothing. So
yeah. So if they're truly co-managing, they have to fill out an application with us to be able to do it. And they actually have to converse with us and do a true co-management back and forth, send us imaging, send us reporting back and forth. And that's the only way that we're actually going to be, co-managing and then providing these funds. If they send us a patient in general and don't have that process already instituted, then I'm sorry, we can't go through that process. Stark laws, we're not going to be able to make that happen.
Right. Okay.
So that's the way that we've put it together. But for the doctors that we've partnered with, we actually have 15 doctors now that we did a launch program where we bought them all mybographers. Actually, we said, look, we are going to buy you a mybographer just so you can do the scans. And if you do the scans and send us the patients and show that they have MGD, then we're building this relationship back and forth. As long as you send us X many patients per however long per month, then it pays for their machine. They don't have to pay us for it outright. And, we're making the patients happy back and forth. It's unique. It's definitely working through. And then especially now we're getting ophthalmologists who refer to us because they don't want to see a lot of the dry eye care and certain practices that are in our area. And they're surprised to be able to get a co-management check back from us. They're like, what just happened? So it's a nice little just perk to say, those guys are doing something a little bit different. They're elevating a high level of care, but they're also penetrating the industry too. So feel free to contact me. I'll put my email in as well too to be able to talk through how we're doing it, and you can institute it in your practice too.
I love the accountability system you have. So it sounds like you developed some automation or software to keep track of who's sending you what and how much to pay them. And that is super important because when you miss a payment, it's like, okay, this system's broken, not referring to that person anymore. Mm-hmm. I did want to talk about how to initiate the referral, and ophthalmology in Kansas City does it really well. So patient has cataract surgery. Let's say it's on the right eye. The patient core coordinator calls, Hi, Dr. Brill's office. This is Cindy at Dr. Pohl's office. I would like to schedule a 1-week follow-up or a next day follow-up. And so you can do the same if you have a dry eye patient, and let's say you don't like doing dry eye, and that's okay if you're here and you don't like it. Just call. You have to set up the appointment for the patient, make it easy, because patients, they'll ask you, well, how do I set up an appointment? It's like they lost all adulting capabilities when they need to go book a dry eye evaluation. So I recommend just doing it on the spot if you're comfortable with that. You could assign that to a technician or someone else. And then I did want to share one anecdote to, to wrap this up. So I was on an IT software startup networking call like this about 3 months ago. And I somehow was describing what I do in the profession. And actually Dr. Pham's product Zocular came up in it as I was going through it. We were talking about B2C and B2B because I think Dr. Pham, you're in kind of both markets, obviously. And what happened was this guy hit me up on LinkedIn. He connected to me and he said, "Hey, Perry, you were talking about dry eye. I have dry eye." And I don't know if it was an optometrist or ophthalmologist, they neglected to treat him. And here he is hitting up a non-doctor for dry eye advice, because I seem like the smartest one in the house, obviously. And so this kind of goes to the point, if you do not refer, the patient will find their way. So I obviously said, "Hey, where do you live? Do you live in North Carolina?" I just typed in some zip codes. I did research for 10 minutes and sent them to a few doctors. And so just be aware, if you don't refer, that you lose them right away.
Right.
Anyways, thanks everyone for being here tonight. We have 31 people that stuck on like the whole time, which is amazing. Thank you so much. Thanks, Felicia and Keith. I think Shannon was on here earlier for hanging on video. You guys are the real MVPs here. And thank you, Eyes on Shepherd crew as well. I think I learned so much. And the chat transcript I do have saved. If anybody wants it, you probably got a text or email tonight. I can more than welcome to send that to you. And then lastly, these are going to go on YouTube and be published as a podcast here as well. So if you want to refer back, listen to it in the car, we'll get those links out.
And tell your friends who are missing out. I mean, I think because everybody's so siloed, this is a nice way for them to learn a lot without listening to a webinar, and tell them not to worry about getting CE credits for it. This is the type of discussion where I just went to the American Academy of Optometry, but most of the things you learn in a hallway, because when somebody's presenting a lecture, they often embellish, they tell things that they don't really do. And so this is all kind of a hallway discussion where you could ask any question without looking like you're dumb. And of course, this is a very advanced group here. But this is a great way to get information and to learn from the best. And I think Eyes on Shepherd, you guys are stellar. We never even knew you existed here in the States, because that huge wall that we have between these two countries. So
yeah. And if anyone's in the Toronto area, come stop by. Carrie loves giving tours, as you saw, but anytime.
Awesome.
And Toronto's a great city for those in the US who haven't been there. Great transportation. People dress nice. They go out during the night. They go out during the middle of the week. They don't do everything just on Friday and Saturday. And
the mall's underground.
Yeah, buses connect to trains. I know one, I'll just tell us, I took a train and then I was going to get off and go on the bus. I said, "Well, I need a transfer." And I asked it like 5 different times. And I said, "Well, how do they know you got off the train, you're going on the bus?" And they said, "Well, you're not supposed to do that. They treat you like you're honest." They may have changed, but in the US, somebody would say, "Hey, there's a scam. You could just get on the bus." So, but Toronto is a great city and great metro area. And in fact, I had a brother that lived there for about 30 years. So.
Well, thanks for the endorsement, Perry and Raymond. Thank you, and thank you for establishing this forum. This is great, and it really fosters a lot of crosstalk and networking. So thank you for your efforts.
Yeah, and if anybody would like introductions to any of these people, feel free to hit me up via text or email. Last event, I had like 10 people were like, "Hey, I like what that guy said or that woman said. Can I get an intro email?" And you guys can become besties. So. All right, everybody. Thanks. And we'll see you in 2 weeks. I don't know the topic yet, but we'll figure it out. So.
Okay. Thanks, everyone. Appreciate it. Bye-bye.
Bye, guys. Thanks for a good night.
Bye-bye.